today, Dr. Stone will be talking about the diabetic foot, what you need to know. It's a very important talk, actually.
Thank you. So we're going to switch gears now and talk a little bit about the diabetic foot, which is quite a wide and diverse topic. No disclosure. In the past 30 years, the incidence of diabetes among the world's adult population has nearly quadrupled, rising over 422 million individuals worldwide, a number expected to increase by 642 million in 2040. In the U.S., 29.1 million people, which is almost 9.5% of the population, have diabetes. 21 million are diagnosed, and another 8 million undiagnosed. People affected by diabetes have a 25% lifetime risk of developing a diabetic foot ulceration. Annually, we spend $480 billion worldwide towards the treatment of these diabetic foot ulcers. 6 million people in the U.S. have chronic, non-healing foot ulcers. This costs the healthcare system more than $3 billion per year. The most common chronic wounds are found in the lower extremities. 98% of these chronic ulcers are either vascular or diabetic in etiology. 85% of these affect patients who are 65 years or older. These diabetic foot ulcers are considered chronic. They've not gone through an orderly and a timely healing process, which produces anatomical and functional integrity over 3 months. These have not shown a 15% reduction weekly, or approximately a 50% half the wound should be healed surface area over a 1-month time frame. Diabetic foot infections are often a serious consequence of these diabetic foot ulcers. Diabetic foot infections are the most common cause of non-traumatic foot amputations in the United States. 15% of these foot ulcers result in a more proximal amputation, leading to high rates of mortality in under 5 years. In 2008, Driver and colleagues reported that uncomplicated diabetic foot ulcers cost upwards of $8,000 per hospital stay. Infected foot ulcers up to $17,000. And if amputations are required, it can jump up to $45,000 per person. These numbers in today's hospital have almost doubled. Peripheral vascular disease equates the cost of treating a neuropathic wound, diabetic foot ulcer, by 4 times. Diabetic foot ulcer recurrence reported as high as 34% at 1 year, 61% at 3, and then 70% foot recurrence at 5 years. The existing prevention methods do have the potential to decrease the risk of amputation in diabetics with an ulcer history by up to 50%. So as quality healthcare providers, we are striving to perfect the remission of the diabetic foot. We want to keep these ulcers healed and keep them from recurring. A few more statistics. 93% of the vascular-related amputations in the U.S. are associated with diabetes. However, peripheral arterial disease without diabetes is another leading cause of lower extremity amputations. Peripheral arterial disease is progressive, a disease that can lead to critical ischemia, which is the most advanced form. Up to 10% of the global population has peripheral arterial disease, with an increase in 15 to 30% as a patient becomes older, especially 70 years old and with diabetes. These critical and ischemic patients require revascularization, and even with surgery, the amputation rates can reach up to 25%. So we know about the peripheral arterial disease workup. We check the pedal pulses, the digital refill. People with shiny, hairless digits are the initial key. Pallor with elevation and movement with dependency, the Berger's test. These patients will be sitting in a chair, their leg will be hanging down, and their foot will be red. You raise the foot to a 45-degree angle as they're laying back, and the foot will instantaneously turn white. That's the pallor. Also, intermittent claudication and rest pain. The risk factors include smoking, diabetes, genetics, hyperlipidemia, and lower extremity ulcerations. So the PID workup, we do the non-invasive vascular studies, the ankle brachial indices, pulse volume recordings. These may or may not show an occlusive lesion. If you suspect it, then next we perform an angiogram, the CTA, the MRA, or the diagnostic angiogram that Dr. Haqqani just went through. So these foot ulcers result from a combination of neuropathy, vascular disease, and pressure and shear and/or infection. Diabetic foot ulcers are quite complicated. These high glycemic states in these diabetic patients lead to the development of glycoproteins, thickening the basement membrane of the tissues, endothelial proliferation, decreased vessel permeability, and then altered cell migration. This extracellular matrix degradation and the faulty cellular regulation induce high concentrations of inflammatory cytokines within the wound environment. Old cells, senescence, especially the fibroblasts, and increased protease enzymes develop. These cascades degrade growth factors, which are necessary for healing, receptors, the wound matrix, and the support structures. Angiogenesis decreases, and an environment with an imbalance of these nasty little matrix metalloproteases, MMPs, and tissue inhibitor matrix metalloproteinases develop and inhibit wound healing. So just a few factors again for healing wounds: poor vascular supply, mechanical pressures, especially shears of pressure at an angle, specifically to the foot where it's pertinent is at an angle 45 or 30 degree, not specifically perpendicular. Poor glycemic control, albumin levels anything below the normal 3.5. Infections, which can produce biofilms. Neuropathy, sensory motor autonomic. Unrecognized foot trauma, especially foreign bodies. And diminished growth factors, collagen and hyaluronic acid. And we talked about the elevated MMPs. This is a wound diagram which shows what these reparative cells are used for. The fibroblasts, they produce collagen. You see the keratinocytes, and these are responsible for producing growth factors. And then the epithelial cells, the green cell, are in the periphery. And these work together in the extracellular matrix of a wound to promote healing, epithelialization. The wound heals from the outside in. So options for diabetic foot ulcers include debridement, sharp or ultrasonic. You have to control inflammation and infection. Revascularization is paramount. Local wound care, and then offloading. Contact casting, pressure relief boots now that are developing, and then these instant contact casts are really popular. Larval therapy has been used, hyperbaric oxygen, negative pressure wound therapy, and the system of a vacuum system that can be applied. I'll show you some pictures of this in a little bit. And today we have a lot of these advanced skin substitutes that are on the market. I have a couple of favorites. TheraSkin, which is a split thickness skin graft. It's a human preserved cryogenic allograft taken within 24 hours post-mortem. And then Epifix is a dehydrated human amniotic chorionic memory, which comes from C-section placental births. And then collagen, which is an important structure in the extracellular matrix. This is a busy slide, but it takes us back into our days when we learned about wound healing. The inflammatory phase, the proliferative phase, and then the maturation phase. As you can see, collagen is involved and really assists in the wound healing. It assists with blood flow, blood control, it attracts macrophages, enhances the inflammatory infiltrate, and improves wound cleansing. It forms a scaffold, it attracts additional fibroblasts to the site for growth, and it aids in the deposit of collagen fibers. And in the final phases of healing, it improves strength, replaces and reinforces the scar tissue. So the emergency recommends that all patients with diabetes see a lower extremity specialist for routine foot screenings, depending on need. They need to see a lower extremity specialist at least every 6 months for basic evaluation, and at least 2 months for those greater risk for diabetic foot ulcers. Foot inspections at home. Have them use a mirror if they need to see their feet. Diabetic seamless socks reduce frictions. Foot exercising to promote circulation. And simple control of fungal infections. Topical antifungals or hydrating lotions if the skin is dry. Inform at-risk patients to avoid self-damaging activity like walking around barefooted, running out to the mailbox with no shoes on, walking out on the deck without shoes, picking up splinters. Ill-fitting footwear, they need to control their diabetes, and obtain and maintain their medical professional foot inspection and routine nail care. So let's talk about neuropathy a little bit. It's basically defined as nerve damage caused by high blood sugar levels. 30% of the diabetic population and 70% of patients with diabetes greater than 10 years will develop neuropathy. That's a significant statistic. These high blood sugar levels cause chemical changes within the nerve cells that lessen the supply of blood that goes to the functioning nerves. The three basic types are autonomic, sensory, and motor neuropathy. These changes damage the nerve's ability to transmit signals. Neuropathy symptoms are usually numbness, pain, burning, tingling, generally in the feet or hands, sometimes even affecting the leg. It can also affect internal organs, leading to indigestion, diarrhea, rapid heart rates, abnormal sweating, and genital and urinary problems. These patients have a decreased sensory perception of vibration, temperature, touch, and pain. These are all warning signals. These are all little warnings that the patients lose. This is just an example of ischemia. It's a clear piece of glass, and you can see the pressure over the wound. And if this ischemia, which is something you can see taking place inside of a tight shoe, pushes on specifically a digit, and these patients are walking around and they don't have these vibrations, touch, these pain symptoms, they can develop an ulceration. The tissue will die, the blood vessels will hemorrhage, and you develop an initial ulceration, a blister, things of that nature. So autonomic neuropathy basically causes sweating difficulties. Decreased sweating in the extremities, your skin becomes dry, scaly, and cracked. This can also lead to infections like cellulitis. A couple of easy office exams. You can use a tuning fork, a monofilament. There are a couple of rotator devices that you can check for these sensations. Motor neuropathy affects the small intrinsic muscles of the foot, lumbricals, which control the digits imbalance, and then the flexors and extensor imbalance causes contracture of the digits. This is a classic cause of a hammer and a claw toe. The big toe joint, or the metatarsophalangeal joints, where the digits in the foot may become unstable, and the metatarsal heads, which is the ball of the foot that we bear weight on, become very prominent. And then motor neuropathy, soft tissue covering the ball of the foot is exposed to abnormal pressures with walking and standing. Callus formation develops. This is the precursor to the diabetic foot ulcer. This can lead to pressure ulcerations. You can see we talked about the metatarsophalangeal joints, which are the forefoot areas. Specifically, the slide on the left, you can see these hyperkeratotic areas develop. That tissue needs to be removed. That is a diabetic foot wound waiting to happen if that isn't removed. The person on the right has 3 lesion sites. These diabetic foot wounds can occur anywhere on the tips of the feet. They can occur on the top of the digit, on the sides. There's a central foot wound. There's kind of a lateral foot ulcer in the plantar aspect. The notorious heel ulcers, these are extremely difficult. They're hard to heal. The patients are non-ambulatory for months on end. And it's a challenging topic. On the right, it shows that this patient was treated with negative pressure therapy. This is the wound vac. It's a device that uses a granular foam attached to the wound. You can actually bridge it so that you can bring it up on the top of the foot or wherever you're using it on the body, and in the vacuum system, and you can see the portable vacuum. So preventing wounds is a necessity, and we look at reducing peak plantar pressures. So repetitive pedal stresses in the presence of neuropathy, bony prominences, or peripheral vascular disease augments the rise of these diabetic foot ulcers. So we want to redistribute these plantar pressures. Neuropathy and a decreased metabolic response renders these patients unable to organically detect these stresses and trauma to their structures. diabetic patients are shown to regularly have elevated peak plantar pressures, greater than 200 kilopascals. This is a pressure threshold which is shown to maintain previous ulcerated sites. So these offloading devices, despite the crutches or the rollabout, the knee scooters, or the knee scooters that we've seen, come in many shapes and sizes. Ucioli and his companions in diabetes care found ulcer recurrence rates in normal foot gear to be more than 200% higher in patients using diabetic certified shoes. It is imperative that these patients with polyneuropathy or PVD or these other complicating factors convert to diabetic shoes. Total contact casting is useful for wounds. It can be expensive, there's a high learning curve, it can cause other wounds. Patients don't like to be casted. The casts today have less lengthy applications. In the past, it was quite a process to apply these. The instant contact cast is something that's developed over the past few years. Short application time is less expensive. It's not quite as dangerous for the patients when they use it, and there's an easy learning curve and less patient apprehension. So these are basically in-shoe devices. These are orthotics that come in shapes and sizes, made out of anything. Years ago they were made out of metal. Now there's thermoplastics. They're quite light, they're comfortable, they're moldable, and you can put some accommodated tops. Plastizo, PPT, or soft foams, or open cell. They accommodate very well. And this is a biofoam impression system that we do right in the office. And here's an offloading device. This is a 1-inch thick. It has multiple foam densities. You can take these hexagonal pads out to offload the area. This just shows to maintain the structural stability of the foot. Not only are we maintaining the arch of the mechanics of the foot, and maintaining soft tissue offloading. This is a diabetic shoe. You can see that the crest is over the foot wounds. There are little indentations in the forefoot where the toes are actually causing pressure. This patient is overloading the forefoot. You can see the hex, the DH pressure release shoe on the left, and then an AFO type of device. And another shoe, an AFO, more diabetic shoes. If you can see the left, this patient has a digital forefoot amputations, and you can accommodate the foam to fit the foot and eliminate sliding movement. And they can actually wear a full shoe. They don't have to have a half a shoe, so it doesn't look like they have some sort of amputation. This patient obviously has lost the 3 rays on the lateral aspect of the foot. The shoe was accommodated quite nicely with a multi-density insole. A nice shoe that she would wear. The shoe has a graphite shank to add stability, so she's able to walk. She doesn't have the normal heel-to-toe gait that we would, but she's able to function quite well, and she's very pleased as several physicians wanted to amputate her foot. Again, this is another offloading device that we use. This is a crow boot, a sharply restrained orthotic walker. These are like a clam or a valve shell. These are very good at offloading patients. You can customize these. This gentleman was a veteran, so you can see this patriotic crow boot. And here's now a modified shoe. So treatments, debridement, to control infection with IV or oral antibiotics, offloading devices that we talked about, appropriate shoes with the insoles, and these new technologies, the negative pressure, hyperbaric oxygen, gene therapies, growth factors, and these biological skin grafts. And all the dressings out there, and then surgery. So we talked about offloading. These wounds need to be debrided. All non-viable tissue needs to be removed at a regular basis, sometimes as often as weekly. Collagen, which we talked about, is very important in the wound matrix. It's made a resurgence. We used it about 15 years ago, and then it disappeared a little bit, and now it's really coming back. I think they're able to obtain it. More and more insurance companies are on board with using collagen. They know it's a vital tool for treating these wounds. So basically it comes in a sterilized packet. The wounds are debrided, non-vital tissue is removed. You have a healthy wound that, and then the collagen, I prefer the granules. It comes in some fold sizes. Put that into the wound and then you dress that, and that usually stays in for 5 to 7 days. We talked about Fungal infections in the nails, these things can cause digital lesions, it can cause infections. This needs to be maintained. In nail infections, they need to be removed, drained, permanently ablated if necessary. So let's talk about offloading surgically. With forefoot deformities, specifically hammer, claw toes, metalhead deformities, and interestingly, the rates of infection post-digital surgery in patients with diabetes parallels those of patients without diabetes. A simple in-office procedure and a very beneficial procedure is the flexor tenotomy. When the patient has a hammer toe, which is a digital contracture, they often develop a wound on the end of the toe. This is a 1 week post-flexor tenotomy. On the big slide on the right, you can see a small crack. That's the incision. The digit was contracted. It has to be reducible. The toe has to be able to move. It cannot be rigid. And here we are at 3 weeks. The wound is pretty healed. You can see the toe's straight. It's not contracted. And the diabetic foot wound is no more than a healed callus now. So diabetic lesions in the forefoot can occur anywhere on the inside of the toe. They can occur in the metatarsal heads, digits, top, sides. Here's an infected digit. The slide on the right shows that the bone is actually exposed. Some of these are just simply treated with amputations. Forefoot lesions. These are debrided. These are callous. You can see the contraction of the digits, which are causing these metatarsal heads to be more plantar prominent. And here we are after we've repaired that. The ulcers were excised. The hammer toes were straightened, pinned. The metatarsal parabola was maintained, and this patient will function quite well. Here's another wound in the lateral foot. This patient has lost the lateral digits, and this is after debridement. This is a Theraskin, a cryopreserved allograft that works quite well. This comes in a frozen container with dry ice, and we thaw it and hydrate it, and then apply it. This shows digital surgery. All digits were pinned with contractures, and this is 4 weeks post-digital surgery. And then another forefoot condition is the hallux abductor valgus, or the bunions. And it's an angular rotational deformity involving dislocation at the great toe joint. You have pain, prominence, swelling, redness, difficulty fitting shoes. Some of these can be quite horrendous, and you can see how hard this foot would be for a normal shoe. These patients all need custom diabetic shoes and offloading. Here's a bunion and a digital arthroplasty at 2 weeks. And you can see the different forms of fixation, whether you use pins. There are a lot of different fixation devices. Some of these metals now are heat sensitive, and they'll move and they'll contract, and they help to garner fixation in the digits. And here's a bunion, a tendon transfer, a shortening, second metatarsal osteotomy, and a hammer toe. Here you can see the digital deformities. Some of them can be pretty pronounced, the dislocation of the digits, and then post-operatively the slide on the right shows a fixation, and then the great toe was actually pinned as well. It essentially overloads the forefoot, which increases these peak plantar pressures that we talked about. The peak plantar pressures are reduced by 28%, almost 30%, for the posterior calf lengthening, either the Achilles tendon lengthening or the endoscopic gastroc recession. As you can imagine, if you're cutting your Achilles tendon and you're lengthening it, that immobilizes you for several weeks. I don't think there's really anyone in here, unless you had to, would want your Achilles tendon cut. So the gastroc recession is done with a small incision, about 1 centimeter, up into the mid-calf between the Achilles tendon and the gastroc muscle. There's an epineuritis, a band of tissue, and you can see the endoscope placed on the left, and on the right, up at the top of the view box, you can see the released aponeurosis and then the muscle. Midfoot procedures help stabilize, realign, allow the foot to function. Reducing these deformities, there are a lot of devices you can use to fixate these. The slide on the left shows a first-rate amputation, the great toe all the way to the base of the midfoot, and then just some hardware fixation of the midfoot. Here's another chronic wound. The wound has been debrided, and there bearskin graft has been applied. This patient had a diabetic foot infection, resulted in osteomyelitis in the digit. You can see the nature of the wound on the left, and after removal of the infected metatarsal, wound care, debridements, you can see where she's doing very well on the right now, and almost, I saw her last week, and she's essentially healed at this point. Platelet-rich plasma is another nice modality or a little trick that we have. Basically, you take the patient's blood, you centrifuge it down, you have a platelet board, a platelet-rich plasma. These can be injected into wounds and used with grafts. They're great with bone healing. The patient's own cells are used to help him heal, especially the platelet-rich plasma. Just another midfoot wound, the entire foot. This person had an amputation of the whole fifth ray, bone infection, antibiotic beads. You can see these midfoot amputations. Can salvage the foot. You have to watch your metatarsal parabola to make sure that they can bear weight. And quite often with the midfoot procedure, something to this shape or form, you need a posterior calf lengthening, a TL or EDR. You can see they come in different lengths and sizes, and rotational things you can do, and the ulcerations are plantar. You can move, and some of these flaps are reattached. And this patient also had an Achilles tendon lengthening. I don't know if you can see the back of the heel there to offload the forefoot. This person had a partial calcanectomy, which means the heel bone was removed with a large stage 3 ulceration. On the right, you can actually see these little beads. About a third of the heel bone, maybe a half of the heel bone was removed so that the wound could be closed. With the infection, these antibiotic beads, we apply vancomycin or tobramycin antibiotic and a calcium phosphate structure, and this is nice because they're absorbable. Now, years ago, we used to mix them with the old polymethyl methacrylic knee cements, and we would remove these, but it would still elute antibiotic into the tissues. Now they're absorbable. We put them in there, 6-8 weeks, and these antibiotic beads are gone. Here's a challenging another heel ulcer. You can see the necrosis. These are often will lead to an amputation, but sometimes we can save them. It's hard to offload. So we need to debride these, get them clean, get them offloaded, control the antibiotics. We should make sure the vascular status is adequate, and then we can perform grafting. Another significant consequence of the diabetic foot is the musculoskeletal deformity. Charcot foot is neuropathic arthroplasty, and it's basically a chronic progressive degenerative dislocating disease of one or more bones and joints. It's identified by swelling, intra-bone bleeding, increased temperature, which is important, bone changes, and joint instability. So 14% overall recurrence rate in re-ulceration of patients with prior diabetic foot ulcers who underwent a prophylactic surgery offloading versus a 40% rate of recurrence in patients whose treatments were limited to non-surgical therapies alone. So surgical offloading does work. Now we're working on some plantar fat pad augmentations for the patients with fat pad issues. There are some silicone fillers. These are limited. The limitations are availability. Some people have reactions to silicone, and this is not mainstream at this point. Autologous fat grafting, lipofilling as it's called, injections from the abdomen. We've had some issues with the staying power of this. It would be nice if we could just inject some adipose out of the belly, inject it under the metatarsal heads of the foot or in the heel, but it isn't quite that easy. Some other human tissues like rat jacket and dermaspan, which are basically dehydrated allergenic skin products, have shown some good clinical results. I've used these 15, 20 times, and they work quite well. We're basically just putting cushioning under the areas that need it. So future technologies, heat, redness, and high peak plantar pressures are some of the earliest clinical indications of inflammation that marks initiation of ulcer formation. In the future, the integration of wearable sensors, medical telemetry, these intelligent insoles or smart socks could potentially alert the user of warmth and pressure dangers by real-time analysis. 10 to 40% of patients with diabetes also have a form of vascular disease. and a comorbid factor increases by the likelihood of ulcerative recurrence by a factor of 10. Vascular disease and peripheral neuropathy also have higher reulceration and amputation rates than those of neuropathy alone, as you can imagine. The predominance of neuropathic ulcers continues to shift toward the neuroischemic and the increasing adoption of the toe and flow multidisciplinary model. The podiatric surgeons and vascular surgeons personify the backbone of the diabetes wound management team, which will see accelerated implementation. So these diabetic foot wounds need a multidisciplinary team. They need lots of healthcare practitioners involved. These coordinated professional teams, this team approach, which has been utilized more and more over the past several years, seem to decrease the frequency of limb loss by as much as 70%. And we need to perpetuate diabetic foot remissions worldwide. That's our overall goal, keep these feet from re-ulcerating.